Hello, welcome to Ask the Doulas. I am Melissa Benaplos. I am sitting here today with two lovely ladies, Katie Swanson and Shira Johnson, and we are going to talk about breastfeeding and oral growth and development. Hello.
Hello.
So we don't really have an agenda for what we're going to talk about per se, but before we started, I was kind of asking as a dentist, do you send clients to a lactation consultant, or does the lactation consultant send clients to a dentist, and how soon, and what does that relationship even look like?
Yeah, I
Who
guess.
wants to start?
Shira, what do you see in a patient that means you want to send them to me, I guess? Yeah.
Yeah, so I see babies of all ages. I see newborn babies, I see older babies, and really, regardless of the age, if I am noticing something, I'm always seeing them in some capacity related to feeding, usually breastfeeding. And when I'm seeing them and there are any kinds of feeding difficulties, I do an oral exam, and if I'm noticing anything out of the ordinary or anything that might suggest that the baby's having trouble using their mouth optimally, then I often refer to a dentist.
Even as a newborn?
Even as a newborn. Yeah, so infants can have things going on with their mouth. Maybe people have probably heard of tongue tie, so that's one example of something that I might be looking for signs and symptoms of.
Should we talk a little bit more about tongue tie? Because I know you have a very special machine.
Yeah, so absolutely. When I, meet a baby for the first time, we do an exam with mom, dad, or whoever the caregiver is, where we, examine the mouth and all the attachments in the mouth. We have an attachment from our lip to our gums. We have an attachment of tissue from our tongue to the bottom of our mouths, and we have even other attachments in our mouth, even with our cheeks, to our gum tissue, called buccal ties that we've talked about a little bit, me and Shira. And all of these attachments in their mouths can actually affect the movement of the tongue, the lip, the cheeks, and how they actually are able to breastfeed. So when I see a patient, I'm doing an exam typically just with my fingers, kind of playing, tickling around in their mouth and stretching the lip and moving the tongue around and kind of seeing what kind of movement they have. And even evaluating, a tongue tie is actually fairly easy to identify with a baby when they open, or if they start crying a little bit. Their tongue actually almost forms into a bowl if they're tongue-tied, and that's a pretty telltale sign. Whereas otherwise, when they're crying, typically their tongue will raise, and that helps me see how much movement they have as well. So I don't know if you want to talk a little bit more about
what are your first signs? I'm curious as to what do you notice right away with the tongue tie?
So even before I do an oral exam, just talking with the family and hearing the story of how breastfeeding is going or how it's gone, hearing different kind of red flag symptoms, which can really vary from family to family, but certain things, pain with breastfeeding. So we consider it normal to have some pain, nipple pain with breastfeeding during the first week after baby's born, but then it should subside, and there should be no pain associated with breastfeeding after week 1.
And the initial pain is just like with your nipple's getting a lot more action than it probably ever has.
Yeah,
so
there's some hormones on board too that can make nipples more sensitive. But any kind of nipple damage, if baby's nursing and causing cracks or bleeding or scabs, that's one sign that the latch isn't right. And there are a number of reasons. It could be positioning, but often it's really what's going on with baby's mouth that affects whether the latch is a good latch or a comfortable latch.
Okay.
Yeah, and then in addition to how comfortable it is for the mom and for the baby, the latch also determines how effective the breastfeeding session is. So a baby that has some of these oral restrictions going on may not be able to remove milk from the breast as effectively, as efficiently. So the feedings may go on a very long time. Baby may be struggling with weight gain. So those are some other kind of common signs. But then there are some babies that don't have those signs and they still have a tongue tie. So it's a little harder to detect.
And then you would kind of actually, like Katie does, actually look in their mouth and look for something specific.
Yeah, and I do that too. I also, in addition to kind of interviewing the family and watching a breastfeeding session, in most of my lactation visits, I'll get gloves on and really examine the baby's mouth. And similar to what Katie said, look under their tongue, feel around their lips and their cheeks, and I let the baby suck on my gloved finger, so I feel what the suck feels like. And there's a certain movement that the tongue is supposed to do, a wave-like kind of undulation kind of movement when they're sucking. So if there's any variation in that, I note that. Sometimes babies they hold on really tight with their gums, and it almost feels like they're biting. And that's a sign maybe that they're needing to compensate with other facial muscles rather than letting the tongue do its job. So there are just lots of different little clues that we look at, and if all the pieces come together, it can potentially point to a probable tongue tie. And as an IBCLC, an International Board Certified Lactation Consultant, it's not in my scope of practice to diagnose anything. So when I notice all these symptoms, if things are looking like there is an oral restriction going on, that's when I would refer to a pediatric dentist.
And you can diagnose and
and so
treat.
What's great about, being a pediatric dentist is, I'm very familiar more with the growth and development of infants and kids, but not all pediatric dentists are actually trained in really how to evaluate and treat frenectomies. Even as I am a board certified pediatric dentist, and that doesn't necessarily entail that I can treat frenectomies, but how I've been able to acquire this knowledge is through taking a lot more courses in order to be able to understand frenectomies and how it affects the whole body and how it affects feeding and speech, and it affects children from honestly in utero when they're still developing, and how it affects the whole body's growth. And obviously the first sign typically is how well they latch and how mom and baby are doing those first few weeks of life when they are able to start feeding. But definitely it's really important that I and my business partner, Dr. Klostra, have taken these courses so we can, work with lactation consultants and better understand, how to evaluate for this and how to work with other specialists as well, like Shira, in order to make sure we're giving those patients the best treatment possible as well. Absolutely. What's interesting, so when you're developing in utero, obviously all the tissues are developing, the muscles are developing, and when you have a little bit too strong of attachments in certain areas with what's called fascia, it's basically tissue attachments in our body. We have it, in our face, it's between our lungs and all of that. It's between our organs and muscles and all of that kind of tissue. And sometimes, obviously in your mouth, you might have a little bit of extra tissue, and that's when a tongue tie, lip tie, other ties can develop in the mouth that can actually create a lot of tension in that tissue, and thus tension in muscles that attach to that tissue, which thus, when you have all of that tension, it does affect how their whole body is growing. Even torticollis and other symptoms at birth have been linked to tongue, lip ties, all of that as well. The flat head at birth and things like that too can all be impacted. So it's great when, mommies and babies are, if they're having any difficulties, to seek help from an IBCLC like Shira, because it's an important sign that there's something going on and baby needs some help in order to be able to actually grow and develop normally and comfortably as well too. Yeah.
So did we talk about this on a podcast before? And I'm just asking you this, or was it when we were just talking here about what that looks like when, like, the actual frenectomy? Like I'm scared. I'm a parent. So like they see you, and then you say, "I think this is a tongue tie. I want you to go see the dentist." Katie sees the baby, says, "Yep, this is in fact a tongue tie." Then what?
Right, that's a good thing to talk about.
Yeah.
And we should define frenectomy too.
Okay.
And I often call it frenotomy. So
frenotomy was very like old school, using a scalpel. You're going under general anesthesia, or you're getting sedated, and they are cutting the tissue and suturing it.
Okay.
Putting stitches in.
Okay.
Whereas frenectomy, it's basically just a general term for tissue removal. So that it can be all encompassing, because there's multiple ways to do a frenectomy, and I can definitely talk more about all those options, because really every parent is going to have their own comfort level too, and we have to be respectful of that as well. But generally frenectomy, there's it does mean removal of tissue, and there is more of a surgical approach where typically you would see a ear, nose, throat specialist, an ENT, and there's children's ENT specialists as well that are typically trained at a children's hospital. And if someone wanted to go that route, definitely seeing a children's ENT is the way to go, because just like myself, I am much more, trained on the growth and development of kids and kids' anatomy and how it grows and changes as their body grows and changes. But when you see an ENT, typically the child would have general anesthesia. General anesthesia is a full body anesthetic, meaning they are sleeping. A machine is helping assist with breathing. They're breathing in gases where it's basically triggering an area in the brain to just relax the whole body. So even the lungs, to the point where they need assistance with breathing. It's generally very safe, but there is a lot of research showing that, having general anesthesia before the age of 2 to 3, it can actually have impact on their intellectual and behavioral development. So that's why, because of that research that had come out, there's been a little bit more of involvement with how we do that procedure for infants, because they are so little. Mm-hmm. And obviously their brains are going to be impacted by having general anesthesia. We don't know how specifically, but definitely there's been more recent studies out that were excellent studies done to show, yes, there is definitely an impact, which was very helpful in educating everyone. And so that's why there's been this, things have evolved to the point where there's other options. So there's even multiple kinds of lasers. There's something called electrosurgery, where you essentially basically burn the tissue away. It's another option. It's not the best option, but it's an option that I know has been used. And then there's multiple kinds of lasers, and that was part of my training as a pediatric dentist and going to these courses, and understanding the types of lasers, which ones are going to be best for certain procedures. Definitely the bread and butter for soft tissue tissue removal is something called a CO2 laser. And I guess I don't probably need to go into the science of everything, but generally that has been shown to be the most optimal for soft tissue because of basically its ability to have, less pain, less bleeding, less inflammation, to make sure that soft tissue heals up much faster and the recovery is easier as well. But there's other lasers that are great options that I have also used, and my patients have done great with those as well.
But the CO2 laser is what you currently have.
The CO2 laser is what we have in our office. And definitely after trying lots of lasers, that's the one we really wanted to utilize for our patients. Definitely, I believe other pediatric dentists, even one you've trained with, that's what Dr. Ghaheri had used too. Is the CO2 laser?
I have observed. Dr.
Yeah,
Ghaheri,
you've observed. Yeah, okay. But yes, there's multiple types of lasers that work awesome and are able to provide patients with a great, outcome as well. Absolutely.
Okay, so walk a listener through that. They're a mom who has seen Shira for a lactation visit or two. You say, I believe this is a tongue tie, a lip tie. You need to go to see Dr. Katie. So she goes into your office and you say, yep, sure is. In fact, here's what we're going to do. I know we have talked about this, but what does mom do? What does baby do? What does the lactation consultant do? What do you do? What does this whole process look like for mom going forward or dad?
For doing the actual frenectomy or just, well, I guess for, at our office personally, we do an interview first as well, because I kind of want to check, what symptoms are going on and talk to mom and get to know the family and the baby too, because even getting to know the baby, it's going to help me understand, post-operatively, what kind of exercises will be best for them, things like that. In order to, make sure that the function they gain from the procedure continues and all of that, and working with a lactation consultant afterwards, obviously. The procedure itself, it's one thing is that it needs to be done by someone who's trained to do the procedure, because it's a very quick procedure, but it's a very involved procedure. It's how much we're thinking about and looking at and trying to control in, 2 minutes. But generally, once we interview the family, make sure we see the anatomy, and this is what we think is a good option for the baby. We basically swaddle the baby so they're comfy, have mom, dad, whoever's there, give them a little kiss, and we have them step out while we do the procedure. We have a couple assistants in the room with myself or Dr. Klostra, my business partner, and we use the laser to do the procedure. It takes, again, about 2 minutes to do, to vaporize that tissue. It's very quick.
And what about anesthesia?
Yes, thank you. So I do not use any local anesthetic or topical anesthetic for any infants. From what we've been advised by pediatricians, just with the immaturity of their liver health, it's really not ideal, and topical anesthetic for that young of a kid is actually now not approved by the FDA because it does have such toxic effects. So obviously using a small amount, in a controlled environment is safe, but we really don't want to put any of our really, really little patients at any risk at all. But the procedures we've done, the babies do amazing. So what I observe is they do cry during the procedure. It's generally, a typical coping cry is what I like to call it. They're crying, they're confused, they don't really know what's going on. And then once we're done, after about 2 minutes, we take them out of their swaddle blanket and I basically rock them. And it's kind of amazing how resilient babies are because they calm down immediately. Mm-hmm. Every baby I've seen for this, they calm down immediately. And that's when I have mom come in. And I usually, if they're comfortable with it, I like them to breastfeed just to help relax the baby. And that's really why we don't have parents present in the room, because I want them to be able to swoop in, be their comfort zone, help them relax. I imagine it's very stressful as a parent to actually watch that procedure. I guess I could even compare it to like having your son circumcised at the hospital, a couple days after their birth. It's kind of a similar situation. I don't think I would personally want to watch it, but everyone has what they want to do. How we do it at our office is just really based on what we've observed and learned to make sure that we're optimizing that baby's treatment, to make sure we are in a controlled, super safe environment, and that mom, dad, whoever it is, isn't stressed either, and that they can come in and comfort that baby. Because if mom is stressed at all, it does make it harder for baby as well, because the babies do sense that stress in the mom. Mm-hmm. So that doesn't really help the baby if mom is stressed or feeling anxious. From what I found, babies do great in that scenario, which is awesome. Yeah.
So then they get some exercises to do, and then seeing Shira again, you can then help with. Mm-hmm. And what do those exercises look like? What do you recommend, and what have you done, Shira, for exercises after?
Yeah, so I think, from provider to provider, people that do frenectomies, there tends to be a pretty big range of what's recommended by the provider, as far as there's some wound care, I guess we could call it. Mm-hmm. So where the wound is under the tongue, if the tongue is what's been released, I think it can be really important to keep that wound open, in a sense. We don't want it to heal back onto itself, and the mouth heals so quickly. Mm-hmm. So many providers, and Katie can talk about what she recommends too, but many providers do recommend kind of lifting the tongue to prevent that wound from just healing back on itself. We want to create a lot of space under the tongue to help keep that area open as the tongue heals, so that the tongue is then able to obtain full range of motion, which is the goal of the procedure.
Right. Yeah, and the exercises are really pretty simple, and after the procedure, it's kind of cool how you visually see right away where the tie had been, because after we release the tissue, you basically see a diamond shape on where that tissue was released. So whether it's under the lip or under the tongue, when you would raise the tongue or raise the lip, you would see a diamond shape. And the whole goal is that when you do the exercises, you really want to make sure you're seeing that open diamond appearance. But with the lip, it's really just lifting the lip and raising it so that you see that open diamond. And with the tongue, a few finger sweeps underneath to just make sure it's still open, or just lifting the tongue gently with your fingertip is usually a nice way to go as well. But it doesn't have to be a lengthy process. The moment I just took to talk is you should be done with the exercises.
Mm-hmm. That's what I always describe to parents too, because babies tend to get a little bit upset when parents are doing what some call stretches, lifting the tongue. I think it's probably a little bit uncomfortable, but I say, you do it a handful of times a day, but it can be done in 10 seconds.
Exactly.
You're done.
And then you're done.
And I recommend a lot of other exercises, and they're really kind of personal depending on what is going on with that baby, whether that particular baby has really tight jaws or a stiff neck, or they have a hard time getting a deep latch, or a really sensitive palate and a sensitive gag reflex. So depending on what else is going on as a symptom sort of correlated with that tongue tie or restriction, I may recommend different exercises. And
that's why it's so crucial that even after the procedure, the mom and baby still follow up with a IBCLC like Shira, because she's going to be able to diagnose too, or maybe not diagnose, but definitely observe maybe there's something else going on as well, because the procedure I do, it's not the end all be all. It's not the 100% answer to fix everything going on. Baby's still gonna need a little practice, and whether it's lip positioning, tongue positioning, whatever it might be, and whether they need to go see another specialist as well, like a chiropractor or something like that, to help with, like I had talked about before, all that tension that was in the body. It's probably still there, and sometimes someone else needs to be involved too, and Shira would be really helpful in anticipating those needs too. I think that's an important thing to understand, because I would never want to see a patient and then have them go home and not really have that kind of care that they need, and not have the best results they could have either. Especially, with the wound care, as Shira said, it can be challenging for, moms, dads to do it, because it's hard to make your baby cry, especially when it's already been a very, anxious thing in your life too, having to do the procedure itself. And, I've learned too about like other ways of doing the wound care when they're sleeping and things like that. And definitely, and that's something talking about with the parent too, and following up with them. I like to call them the next day and kind of see how things are going, and then offer them, other ideas for wound care as well. In, just pulling the chin down when they're sleeping, or lifting the lip up gently with their sleeping, things like that. Because definitely what we wouldn't want is, the baby to, if they're not getting the proper care afterwards, to develop some sort of, oral aversion either, with, having the wound care and not getting anything else treated that they might need treated. Because like I said, myself doing the frenectomy, it might not solve everything going on, and they might still have something else going on that can give them some difficulties feeding as well. So that's why it's all very important to work together and communicate.
Yeah,
and
I think this whole topic of oral restriction is it's such an important place where collaborative care comes in, and using a team approach. So
Absolutely.
So you, a provider who can do the physical release, and then a lactation specialist to help support families with any issues related to lactation. So when there's been an oral restriction, there's often issues with mom's milk supply too, because if baby has been ineffective at the breast, that can slowly cause a drop in milk supply. Sometimes we see moms, when babies have an oral restriction, moms' bodies may somehow compensate for that by having an oversupply or a really active, fast letdown. But that doesn't last forever. So making sure that the oral function is addressed early on before there are issues with milk production. So from a milk production standpoint, lactation is really important as well. And like you mentioned, the third piece I think is crucial in most of these cases is somebody, a body worker of some kind, a chiropractor or a body worker that does soft tissue work, or both. And, depending on what is going on with that particular baby, the specialist that would be best for them would probably vary. But yes, I think a team approach is really important, because like you mentioned, that fascia that is the connective tissue that had been holding the tongue is tense elsewhere in the body. So these babies with oral restrictions, they may also be the babies that have digestive issues. They may be constipated or have gas, and that can be related to how their mouth has been functioning. Or they may be babies that are really stiff and don't want to bend their hips, babies that are like stiff as a board, and they seem like they want to stand up when they're 3 weeks old. Those babies, we want babies to not not need to hold so much tension in their bodies. So
yeah, I mean, and like you said, the babies who are spitting up and things like that. One really big red flag is when I hear that a baby is taking reflux medicine.
yes, I'm glad you said that.
Because like we said, all that tension, obviously that is all connecting to their esophagus as well, and down to their stomach and things like that. So, and when they're not having the optimal latch, they're bringing in lots of air into their stomach as well. And all of that can actually mask what is truly going on, and it may think, it's just reflux going on. They just have reflux, but what's missing is the other parts to it is why do they have reflux?
Yeah.
That's always the question that needs to be asked when that young of a baby is having any sort of health problems, is why is that happening? There's probably something anatomical, maybe something functional that is actually causing that issue. Not to say that, some babies may have a true reflux going on, and that absolutely needs to be treated, but what we, I think, we generally want to avoid is having a baby go on, medications, or immediately have to go to a bottle or things like that where they don't need to, and having evaluations done so that we can avoid those things and help them grow optimally and all that good stuff too. So mom is less stressed as well.
Yeah. Well, let's end on a happy note and talk about how like the amazing stories like that we've seen of maybe a really struggling mom and a struggling baby, and then they have this procedure and this whole breastfeeding relationship changes.
I do.
Can you put a number on that? Like how
I would
often?
say, in my experience, and even just from hearing from other practitioners as well, I would say definitely a majority of people who have the procedure do notice improvement afterwards, especially if they're doing this sort of team approach and seeing, getting some body work and doing the exercises afterwards. I do want to emphasize that it's not an instant fix. Yes. So like Katie mentioned, she is a really important piece, the dentist, to do the procedure, but I always try to encourage parents not to expect an instant improvement. As an average, I would say it takes anywhere between 2 and 5 weeks to see real improvement. You may notice a little bit, but it's not going to be like all of a sudden, it's sort of a gradual.
I think that's important to know, because I could see how a mom could say, I'm going to fix this right now.
Yeah.
You're going to do the procedure. You're going to help me do the exercises.
Yeah, and that does happen. I mean, it happens occasionally. You have a mom that has incredible pain nursing, and a baby has a procedure, and the mom can tell a huge difference that first nursing session after the procedure.
Yes.
So that does happen. But I would say more often than not, it's a process, and it can take weeks for that tension to unravel.
Is it almost like retraining the baby? What if it's a 1 week old baby? Like the baby hasn't even been nursing for that long.
Yeah, I would say
they don't need to be retrained. That's only been a week.
Well, they practice sucking and all of this in utero.
Yeah. So they've been practicing for a while.
So when you're saying this affects things in utero,
they're moving around. When they're kicking you, they're probably sucking as well and practicing all that movement.
You see them sucking thumbs and
exactly.
And babies,
ultrasound photos.
Yeah. So babies that have tongue restrictions often also will have a high palate, so the roof of their mouth may be higher or more arced than kind of a more healthy palate shape. And that's because the tongue's normal healthy resting position is on the roof of the mouth. And that starts in utero. So way back, when baby's first developing, the tongue should be hanging out up on the roof of the mouth to shape the mouth. And that was something else we've been talking about too, is how the tongue having its full range of motion is so important, not just for feeding, but for oral development, facial development, jaw development.
Yeah, I know. And one thing I wanted to touch on too is just, it's kind of, babies are amazing. They're very resilient. And, even before I really had taken these courses, my niece, she is somewhat tongue and lip tied. And I'm so sad even now, because my sister had been struggling so much with breastfeeding, having all this spit up and reflux. She would hiccup after almost every feeding, like a lot of hiccuping, things like that, where she didn't really need to have that. And she had worked with a lactation consultant and all of that as well, and it never really truly got resolved. But my sister worked through it and breastfed for a year, and with probably accommodations they both made in order to make it work.
It was extra work.
It was extra work. It didn't need to be that way. But now, things are otherwise happening with my niece. Like she's a thumb sucker. She has a little bit of a lisp and things like that. So that's a really good example where it may have not totally affected feeding for mom and baby, but it can have other impacts later because now she still needs some oral stimulation. So the thumb got involved because her tongue doesn't have full range of movement. Where when we're at rest, and you'll start to think about this now, when you're at rest, you'll notice your tongue goes to your palate.
Mm-hmm.
Hopefully. Otherwise,
you're not
maybe
an
go
adult
see
tongue-tied.
a speech and language pathologist. But that is typically what happens. But because she's tongue-tied, she needs her thumb now to have that stimulation. And that's kind of a sign sometimes as well. Not always, but that can be something as well. And then the little bit minor lisp going on. So now there's a speech situation going on. But it's just a situation where, man, I wish I had gotten involved when she was 3 weeks old, and, but now she's almost 5. So, but it's kind of amazing how babies can grow and change and evolve to get their nutrients and what they need, and same with mom. But again, their growth and development happens years to come. So it is all of that development going on. It can still be impacted later. Mm-hmm. Yeah. I mean, there's been lots of good stories though. I mean, I had one baby, I think she was about 6 weeks old. When I met her, mom had been working with a lactation consultant more briefly and was told that she was probably tied, but they couldn't really tell. Maybe go see a dentist about it. So she had seen a friend of mine who referred her to me because he knew I, could diagnose those kinds of things. And we did do the frenectomy procedure for her lip and tongue. And, definitely the first 48 hours were a little tougher because she's, healing, all of that. But generally did much better as the week went on. And I saw her at 2 weeks and 3 weeks. And, at 2 weeks, so at the time I had seen her, she had baby acne, more or less, like pretty severely, like red rashy, peeling skin, lots of bumps, things like that. And then I saw her 2 weeks later, she had gained weight. She had no longer had baby acne at all. And mom was obviously like much less stressed and much happier. And she was like, it's still a little tough, but when I saw her at that 2 week mark, there was still a little bit of healing going on. I said, let's see her in another week. And I want to see how, after she's 100% healed, how you guys are doing. I saw her after 3 weeks and she was doing so much better. So just like Shira said, again, it takes some time. It does. And I don't know specifically what was going on, but with, lots of kids have baby acne and things like that. That's very normal. But when I saw her after 2 weeks and she had cleared up, I was like, well, maybe it's because mom's less stressed and there's less cortisol in her body, which is our stress hormone. And, who knows? It could be multiple things, but that could have been part of it.
More milk volume.
That's so true as well. Yeah. So lots of things going on where just baby was doing great. And just mom was so helpful for me as well. It was probably one of the first times I had actually really done the procedure for that young of a baby. And mom was really helpful in all the things she was observing as it went, and they were doing great. So that was a good success story and how awesome baby was doing afterwards. And she had been on a reflux medicine.
Oh, really?
And didn't have to take it anymore.
Yeah, that's probably one of the biggest things I see. I see lots of babies that are on reflux meds, and babies who have their tongue tie treated are the babies that tend to no longer need that. Mm-hmm. Mm-hmm. Yeah, that was a symptom of the tongue tie, and it goes away. Yeah, gassiness, things like that. So often, or sleeping longer. A lot of times, babies with a tongue restriction they don't have long sleep cycles. Mm-hmm. They are woken up. Probably it has to do with their tongue not resting on the roof of their mouth, which is kind of the soothing.
Yeah. Well, and part of it too is if they're not effectively draining the breast, they're hungry. I mean, they're waking up. I mean, it's as simple as that. They're hungry.
They fall asleep at the breast because it's really exhausting for them to
I mean, if a
eat.
breastfeeding session takes an hour,
it's like running a marathon for
them
to even breastfeed itself. Yeah. Right. So they're exhausted.
Yeah. So it's not necessarily just what breastfeeding feels like to the mom or that baby is all of a sudden gaining weight, but there are all these other little pieces of health that can be related that maybe no one would have thought would be related. You know, you take a baby to the doctor for gassiness and or digestive things or not sleeping enough, and a tongue tie is rarely the first place. Oral function is not often where they're going to look, but they're definitely related.
That's kind of cool.
Yeah.
So moral of the story is you need to find a team to help
Yes,
support you through this
absolutely.
and be patient once this happens.
Yes.
That don't expect instant results.
And I want to emphasize that you do need to find people who are well trained and familiar with this process, with this procedure, and with assessing oral function in the first place, because I will say that many pediatricians, many dentists many lactation consultants, in fact, are not trained at really assessing what the tongue is doing, what it should be doing. So this situation gets overlooked or even ruled out, even when it's a concern that parents have. It's often ruled out when it really should be addressed.
Well, I know that the two of you, it's kind of your specialty.
Yeah.
Shira, I know it is yours.
So if a parent thinks that they're dealing with these situations, these symptoms, just keep looking for somebody who will listen to you and really give you the help that you
Just
need.
call you.
Right. Yeah, and I mean that, and absolutely, I'm not going to diagnose something if it's not there, but it is really important to go to someone who does who does understand oral function and what should be going on. And obviously as an IBCLC, she has definitely more training in what's going on. And as a pediatric dentist, I've sought out that training. But yes, not even every pediatrician understands how to evaluate it, but that's why I'm a kid specialist of the mouth is a simple way of putting it. So I am always in the mouth, I'm looking at the mouth, and that is my specialty.
It's an important part of the body.
It is.
Well, tell people where to find you.
Yeah, so I am actually in a practice called Pediatric Dental Specialists of West Michigan. We are located at East Paris and Burton in the new Bankston Center. And you can find us online at pdsofwestmi.com or give us a call at 616-608-8898. And we'd love to connect with you and connect you with Shira as well. So
Yeah, you can find Shira on our website, goldcoastdoulas.com. People call for you all the time.
awesome.
Call, email, yeah. People love you. We love you too. We're so happy to have you.
I'm so happy to meet you. Thank you.
Well, thanks for listening, everybody. If you have any questions for either one of these ladies, you can email us, info@goldcoastdoulas.com. Our website is goldcoastdoulas.com. We are on Instagram, Facebook, and you can listen to our podcast, Ask the Doulas, on SoundCloud and iTunes. Thanks for listening. These moments are golden.